BDI Part 1. Completely Edentoulus. McGurry and American College of Prosthodontic ACB has developed 3 systems for edentulous patient, for partial edentulous, and dentate patients. The advantage: improve communication, standardize criteria for outcomes, assessment and research, diagnostic consistency, and simplify decision to refer the patient. 1999, McGarry published an article for completely edentulous. We have classification and diagnostic criteria. Class 1 minimally compromised, Class 2 moderate, Class 3 substantially, and Class 4 severe. For diagnostic criteria specific for completely edentulous: bone height for mandible only, ridge morphology for maxilla, and muscle attachment for the mandible, maxillomandibular relationship. From here, prosthetic surgery and interarch space and tongue anatomy and modifiers is only for Class 3 and 4, except mild systematic disease with oral station for Class 2. Starting with bone height for mandible, Atwood has been described bone resorption as chronic, progressive, irreversible disease process of multifactorial origin. Osteoclast activity increased with hyperparathyroidism and pressure-mediated resorption. The annual resorption 0.5 millimeter in the maxilla, 0.1 and 0.4 millimeter in the mandible. So the mandible is 4 times fold than the maxilla. When bone volume decreases, it will affect denture-bearing area, tissue remaining for reconstruction, facial muscle support, and total facial panoramic X-ray. Measurement from the least vertical height of the mandible. We can measure it from the incisor edge to the vestibule in dentate patient and from alveolar crest in edentulous. Bone height, type 1, the bone height more than or equal 21 millimeter, and it's considered Class 1 according to BDI classification. Type 2, 20 to 16 millimeter in Class 2. Type 3, 15 to 11 millimeter. And type 4, equal or less than 10. The second criteria, ridge morphology of the maxilla. Type A, most favorable. The hard palate morphology and anterior labial and posterior buccal vestibule, and sufficient tuberosity to resist vertical and horizontal movement of denture base. There is well-defined hamular notch and absence of tori. Consider Class 1. Type B, palatal morphology and anterior vestibule resist vertical and horizontal movement of denture base. There is loss of posterior buccal vestibule and poorly defined tuberosity and hamular notch. Maxillary tori are rounded and not affect extension of the denture base. In the opposite, Type C, there is loss of anterior labial vestibule and hyperplastic mobile anterior ridge, so posterior buccal vestibule and palatal morphology offer minimum resistance to vertical and horizontal movement. This is give us minimum support. Reduction of posterior molar space by coronoid process during mandibular opening or extrusive movement. Maxillary tori with bony undercut do not affect the extension of denture base. Type D, no hard palatal form or residual alveolar ridge to resist vertical or horizontal movement of the denture base. Hyperplastic residual anterior ridge, prominent anterior nasal spine, and the maxillary tori undercut that interfere with posterior extension of the denture base. Number 3, muscle attachment in the mandible. The effect of muscle attachment and location are most important to function of the mandible denture. Type A, adequate attachment mucosa most favorable. Type B, no buccal attachment and active mentalis muscle, both of them in Class 1 and 2. Type C, no anterior buccal or lingual vestibule and active genoglossus and mentalis muscle, Class 3. Type D, attached mucosa in posterior only, and Type E, no attached mucosa in any region and active cheek and lip tongue muscle, and both of them consider Class 4. Number 4, maxillomandibular relationship. Class 1, most favorable, tooth position has normal articulation supported by the residual ridge. Class 2 requires tooth position outside normal ridge relation to attain aesthetic phonetics and articulation, like in anterior or posterior tooth position is not supported by residual ridge. Anterior vertical or horizontal overlap exceeds the principle of fully balanced articulation. Class 3, the tooth position also required to be outside the normal ridge relation to attain aesthetic phonetics and articulation, like in anterior or posterior crossbite. So back to BDI classification, class 1, the residual bone height in the mandible, 21 millimeter or greater, ridge morphology in the maxilla or resist vertical and horizontal movement, type A, adequate muscle attachment in the mandible that provide denture stability and retention, type A or B, and class 1 maxillomandibular relationship. Class 2 bone height 20 to 16 millimeter and residual ridge morphology in the maxilla, type A or B. Type B, no buccal vestibule and poor hamular notch, no tori. Location of the muscle attachment with limited influence in denture stability and retention, type A or B. Minor modifiers, mild systemic disease with oral manifestation. Class 3 bone height 15 to 11 millimeter. Ridge morphology of the maxilla, type C, has minimum influence to resist horizontal or vertical movement and minimum support, no anterior vestibule, mobile anterior ridge. Type C muscle attachment, moderate influence on denture stability and retention, no anterior buccal or lingual vestibule, and genoglossus and mentalis muscle attached near to the alveolar crest. Class 1 or 2 or 3 and maxillomandibular relationship. Conditions requiring pre-prosthetic surgery, minor soft or hard tissue, including alveoplasty, simple implant with no graft, extractions, and immediate complete denture. Interarch space 18 to 20 millimeter, large tongue, moderate psychosocial with moderate oral manifestation like xerostomia. Class 4, bone height less than or equal 10 millimeter, residual ridge in the maxillary, type D, which is no anterior or posterior vestibule and presence of tori, muscle attachment of the mandible, type D or E. Type D, attached mucosa in posterior region only, type E, no attached mucosa in any region, and the cheek and the lip moves with the tongue. As well as class 1 or 2 or 3 maxillomandibular relationships. There is major condition requiring pre-prosthetic surgery, soft tissue like vestibular extension with or without soft tissue grafting, hard tissue augmentation, complex implant placement with augmentation, surgical correction of dentofacial deformities, insufficient interarch space that required surgical correction, hyperactivity of the tongue retracted, severe psychosocial condition with severe oral manifestation like gag reflex, temporomandibular joint disorder, maxillomandibular ataxia and coordination, history of paresthesia, refractory patient, a patient who presents with chronic complaints following appropriate therapy. This is the guidelines. Thank you for watching the video and see you next time.